Okay, good afternoon. Thank you for being here. It's my pleasure today to host this event on innovative approaches to opioid use disorder management in the fentanyl era. And we have a star-studded panel here, multidisciplinary, and it's my pleasure to introduce, I guess we'll go in order, but Dr. Glenn Sammis, who is a professor of chemistry at UBC. His research focuses on developing innovative synthetic methods and chemical tools with applications in medicine and public health. His work in synthetic chemistry has implications for pharmaceutical development, as well as his group has contributed to the development of a novel opioid detection device. And he brings a chemical innovation perspective to therapeutic development in the space and in response to an unpredictable drug supply. Next, we have Dr. Kelly Dunn, who is a professor of psychiatry and the director of the Callard Institute for Addiction Medicine at the University of Maryland School of Medicine. She's a leading researcher in opioid use disorder, and her work spans clinical trials, human laboratory studies, and medication development. And she's particularly interested in opioid use disorder and opioid withdrawal management. And she brings deep expertise in translating addiction science into effective therapies, more recently exploring the role of orexin signaling in opioid withdrawal. Next, we have Dr. Victor Lee, who is a concurrent disorder psychiatrist working as a consultant on the Complex Pain and Addiction Service, CPAS, at Vancouver General Hospital. And he also works in the UBC Hospital Mood Disorders Clinic. He's the UBC Institute of Mental Health Marshall Fellow and completed his PhD in neuroscience, his psychiatry residency at UBC, and his addiction training at the VGH Concurrent Disorders Fellowship. And next, we have Dr. Martha Ignaszewski, who is a Harvard and a UCSF trained psychiatrist in adult child and adolescent psychiatry and addiction psychiatry in Canada and the US. She's a clinical assistant professor at UBC and also the senior medical director of the Substance Use and Concurrent Disorders program and the clinical lead of the Substance Use Response and Facilitation Service at BC Children's Hospital. Next, we have Niam Newman Azar, who I've been told is the average 15-year-old. So he'll be providing a youth perspective on this panel. Next, we have Dr. Adam Horowitz, who is a neuroscientist and researcher affiliated with MIT and Harvard. He did his PhD and postdoc at MIT, researching at the MIT Media Lab, and the Harvard Medical School Center for Sleep and Cognition. He co-founded the emerging field of dream engineering. And as the CEO of Dust, he's helping translate sleep and dream science into tools that dramatically improve learning, creativity, and mental health. And last but not least, we have Dr. Pouya Azar, who has kindly agreed to moderate the panel today. So Dr. Pouya Azar is an assistant professor of psychiatry at UBC and a clinician scientist in addiction psychiatry and pain medicine. He leads the Complex Pain and Addiction Service at CPAS within the Department of Psychiatry at Vancouver Coastal Health and the VGH Concurrent Disorders Fellowship. He also co-leads the Substance Use Disorder Clinical Research Unit at the BC Center for Excellence in HIV and AIDS, and he's a pain physician at the VGH Transitional Pain Clinic. So lots of expertise, multidisciplinary panel. I'm really excited for the discussion that will follow. So help me to welcome everyone. Thank you.
Okay. Can everybody hear me okay? Yeah. Okay. Well, thank you everybody for coming. And wow, like I'm so humbled to have such an amazing panel for today's discussion. I do want to start by mentioning that we're gathered here today in the traditional unceded territories of the Musqueam peoples. I also want to start by first acknowledging some of my mentors that are in the audience, particularly Professor Michael Krauss, who kind of took me under his wing when I first started working as an addiction psychiatrist about 10 years ago. So it's always humbling to present in front of your mentors. The other point I wanted to make, as you all know, we're now in the week of the 10th year anniversary of the public health emergency related to the toxic drug supply. And, I can remember when I first started my addiction medicine fellowship about 10 years ago, actually more than 10 years ago, back in 2013, I really wasn't expecting to lose a lot of patients. Back then, fentanyl was not on our radar, and it was my interest was more driven around pharmacology, etc. And then in my first year of fellowship was when we first started to see fentanyl in the drug supply. And that fellowship year, I lost count of the number of people that I had lost due to overdose. What was also very interesting and telling was that very quickly, we realized that the tools we had to treat patients with opioid use disorder in the heroin era were less and less relevant and applicable in the fentanyl era. And the evidence we had to treat patients was less and less relevant. So we very quickly found ourselves in an evidence void. And I think it's quite rare in the history of medicine where there is such a sudden pressure to innovate. Maybe this happened in the HIV/AIDS epidemic, SARS, COVID, and now with fentanyl. Yeah, Dominic, in the camera shot. Do you want me to sit here? Okay. I can stand. Okay, I can sit here as well. I just felt more important standing at the podium, but I'll sit with the commoners, I guess. Okay. So this is a segue to our first question for the panel, and that is that, so we've seen this shift away from heroin, prescription opioids to fentanyl. And so it was fentanyl, then it was more potent fentanyl analogs like carfentanil. And then we started to see additives such as different benzodiazepines that we wouldn't necessarily use clinically, and then alpha agonists, xylazine, medetomidine, etc. And the question is, how has this shift changed the clinical and scientific understanding of opioid use disorder management? And where do the current treatment paradigms fall short? So maybe what I'll do is I'll start with Dr. Sammis and we can move down. And Dr. Sammis, I would like you to maybe speak from a technical perspective. I think you have an interesting journey yourself.
There we go. Thank you so much. I can just speak from the tech side. Again, right. In terms of the treatment side, can't help at all. What I have noticed is a lot of the treatment side is all based on technology. It's about 30 years old. All of the instrumentation that's used, all of that, it's really standard. It's older equipment. It's things that are tried and true, but it's pretty far away from what we're actually using in laboratories. So that's something which I've noticed, especially working with Dr. Azar. We've been working together for, I don't know how many years now, close to 10 years.
That's right.
Yeah, something like that. And one of the excitement things to do is actually bring some of the newer, the academic technology into the medicine, into current use. And I think the thing I'm going to stress, I guess, the most is the importance of not siloing within research. I think for far too long, groups are too siloed. That's right. I think the way to really do it is to expand the horizons, work together. Like Professor Phillips in the back, he and I have been also collaborating for almost 20 years now. Again, but that's strength through collaboration, bringing the new technology, bringing new opportunities into the medicine field, rather than we just talk about repurposing drugs, rather than repurposing, actually coming up with new drugs, new technologies, and what can we do to improve existing technologies.
Mm-hmm. Okay.
Yeah, I'll just add that I think we've talked about this a little bit earlier today, that fentanyl just seems to be a fundamentally different opioid, and the experience, what we knew worked very well to treat heroin use disorder or heroin exposure, and even some of the other commercially produced opioids. I think that we can't necessarily generalize that onto fentanyl, and it feels a bit concerning because it in addition to having extreme need, our patients have more acute needs now than they did. And also our medications are not working as well. And so it just feels like this very urgent public health crisis to figure out in real time, as we are losing people, how we can best meet their needs. And so I do think there's maybe recognizing, kind of publicly discussing this and recognizing that we don't need to be beholden to the ways that we have done things, and we need to really think differently. It would kind of help us move into new areas of innovation.
Yeah, absolutely. I would definitely echo the agreement. I would agree with the statement that fentanyl is fundamentally a little bit different from previous, before it was introduced. One thing I think that's quite striking is that just looking within BC and Vancouver, right, opiate use disorder is now really associated with pretty significant medical and psychiatric comorbidity, whereas previously it wasn't necessarily the case. And some people started there and kind of got into opiate use disorder, and some people had opiate use disorder and then developed all of these issues, right? And whatever the case is, we now have a pretty substantial population where we see a lot of, there's a lot of trauma. There's now a lot of chronic pain issues. There's, psychosis. There's brain damage from all of the overdoses that people have sustained, or simply just the effects of the toxic drug supply, right? So not only are we dealing now with an opiate use disorder crisis, we are dealing with the spillover of all of the social impact that it has on the lives that people lead, the neighborhoods that these people are part of. And so you do really need to take a more holistic approach and avoid getting blinders on to treat it as this is some version of very severe opiate use disorder. It's now a little bit bigger than that, and it needs a little bit more of a holistic solution as well. And of course, talking about evidence void, we already don't know what to do with opiate use disorder. So now on top of all these other things, I guess we can frame it as there's a lot of opportunity for a lot of innovation and thinking outside the box.
This is a bit of a tough question to answer because realistically, I think this has contributed to complexity across the board, from assessment to management to being able to identify appropriate and effective treatments that are able to help retain individuals in care. Certainly from the youth side, opioid use disorder is a rarer diagnosis in youth than it is in adults, just in terms of numbers, but especially with fentanyl and other more synthetic potent opioids dominating the market, and access, at least in BC, to programs like Safer Opioid Supply, we certainly have seen increases in rates of diagnosis, and a sense that with even isolated or opportunistic use of fentanyl, the formation of addictive behaviors comes much more quickly even than it did with fentanyl or other prior opioids. And our ability to manage that with the existing treatment guidelines is much more tricky.
Right.
Yeah, right on. I'll say thanks for having me first. I'm a bit of an outsider on the panel. I'm a sleep person mostly, but I'm hoping it's relevant for folks in the room. And I think I'd like to speak in particular to like why I love the Azar Lab so much is the translational work and the collaborative work. And a lot of hopefully what I'll get to talk about today is things that work within, for instance, the trauma or PTSD field that might be relevant in substance use, and also how weird it is trying to take something from a clinical setting to a commercial setting, from a research setting to a clinical setting, and all the kind of barriers that exist there and how they might be worked around, under, or over. Yeah.
Oh, thank you. So I think one of the things that we are seeing now with this shift is higher and higher complexity in our patients, particularly when it comes to what we describe as polysubstance use. So it's becoming less and less common where I encounter a patient that only uses fentanyl. In fact, to be honest, it's quite rare now to come across a patient that only uses fentanyl. At minimum, most patients will use fentanyl and methamphetamine, and there's good reason for that. But I think I suspect should accompany this change in terms of treating patients more in terms of universal symptoms as opposed to opioid use disorder or methamphetamine use disorder in isolation. So I think that I'd like to direct this question to Kelly and then to Adam and then whoever else that wants to chime in. But what are some thoughts around this concept of universal symptoms? For instance, insomnia, sleep, nightmares, mood, etc., that apply to any substance use as opposed to treating any one particular substance use in isolation?
Yeah, thank you for that question.
Mhm.
This is a topic that I'm very interested in. And I think if you look across the use disorders, we often run clinical trials and design medications and run preclinical studies, really kind of narrowly focus on one specific use disorder. And there's a lot of reasons why we do that. But I've often wondered if that is one of the reasons that some of our discoveries don't make the jump into clinical practice, because it doesn't actually reflect the end person who is, generally individuals who come into treatment have multiple use disorders or they're using multiple substances. And if you really look at the use disorders, there's a lot of commonalities across them. And I think that maybe if we could focus on those commonalities, I think research looking at specific use disorders is valuable, but we could complement it by also looking at these kind of universal symptoms, which to me are things like craving, which is present in all conditions and all use disorders, or insomnia is a severe one. We have changes in mood. We have other kind of things related to that. We even have overlap in the withdrawal syndromes across many of the substances that probably suggest that there are similar neurobiological mechanisms that are driving these things. And I think that it might just help us think differently and also be kind of a ultimate back translation, right? So really understanding what the patients are experiencing and then going back and figuring out how can we find a solution for them, rather than trying to identify a solution in an isolated kind of siloed way and then squeeze it into the healthcare system, which is often, in my opinion, why some of our discoveries haven't made that jump.
Yeah, I mean, I think super well said. I think in the brain sciences, we create categories, and then maybe the next generation of scientists forgets that we made those categories up and takes them as truth and reifies them. And that means that often we get really siloed and focus on one symptom rather than thinking, oh, how are these disorders related? How are they interrelated? How are they bidirectionally feeding each other? So, I mean, the reason I pick sleep, sleep pitch, is sleep is upstream of so many things. If you care about cravings and you care about cognitive control, if you care about mood disorders, if you care about suicidality, if you care about inflammation, if you care on and on, you care, then you gotta care about sleep. And in the context of substance use disorder, curious about insomnia, and I'm curious about nightmares as something that reduces your sleep quality. I'm curious about drug dreams, and I haven't seen, and someone can correct me if I'm wrong, I haven't seen any study that tries an intervention on nightmares or drug use dreams in substance use disorder and sees if it helps somebody, for instance, a patient, and helps their relapse rates. And it's this like, it's really upstream of all these different things, which is why sleep is really wonderful. But the other reason, just to your point, is it's universal. People are really different. If you're going to focus on memory, is that person 65 or are they 25? It's really hard. Mechanisms are going to be really different. There's representational drift. People are really different. Everybody needs slow wave sleep. They're not different. Everyone goes through sleep onset. They're not different. And when you understand a mechanism, if you get good at helping that mechanism along the lymphatic system, whatever, you can help everybody, which is kind of wonderful. So it's universal and upstream. So it helps you not get so siloed.
Yeah, I think, sorry, Kelly, what were you going to make? I think sticking to this theme of sleep, since we're on it, I think one of the things that's important for me is when we do research, for me, it's important that all the research be directly clinically relevant, right? So you brought up this concept of drug dreams or substance using dreams. This is something that's really interesting for me, and it's a phenomena that I've seen in my patients, but it's something that's rarely spoken about. So I have patients that describe this experience of, particularly in early recovery, that they'll have this significant elevation in nightmares, and the theme is typically around substance use. So they'll describe that they'll have nightmares chasing the substance, trying to find it, waking up in a panic because they can't find the fentanyl. Or they'll have a nightmare where they will be right back in that environment where they were using, where all the triggers were. They see the substance, they get it, they start using, and then they wake up tasting or exhaling the fentanyl, or they wake up tasting the vodka. And many of my patients describe that as being a significant trigger to relapse. And many of my patients tell me that they have relapsed as a result of these substance using dreams. So up until now, it's like, okay, this is an interesting phenomena, but what real intervention do we have to modify this risk factor? Can this be a new therapeutic target, a new target of therapeutic intervention? So I think that's where I find your research super fascinating, Adam, because I feel like now, and it's pretty rare in medicine when we have a brand new target of therapeutic intervention, but I feel like we now might with nightmares. Can you talk a little bit about your research?
Totally. Also, yeah, you're saying that your friend Ellis is the one who wrote the Ellis paper, so I get something wrong. Please tell me. Yeah, so that paper in particular, if I remember, it's folks with opioid use disorder. A third of them have these kinds of dreams that Pouya is describing. And of that third, 40% say that relapse was driven by one of these dreams or nightmares. Those stats sound really big, but it's not that surprising if you're from, for instance, like the PTSD world, where like maybe about 80% of folks who come in, get diagnosed with PTSD, they'll have repetitive nightmares, same nightmare every night. And those nightmares predict a 4-fold increase in suicide rates. They're a really big deal for people. And you do a lot and you sit with patients during the day, but at 3 a.m., they're really, really alone. And I bet on this panel and in this room, we could think of so many different tools, exposure therapy, et cetera, to help people with the mind during the day, with stress during the day, with cravings during the day. I bet none of you can tell me one tool for the night, but 20 billion hours were spent dreaming last night. I had no tools for them. It's a crazy thing. And for people with trauma, people with substance use, we just don't have much to hand them so far. So yeah, I'll just say a little bit and then I want to pass it on. But the tools that we build and the collaboration we're starting with the Azar lab, basically ways to change people's dream content and then to see if changing their dream content changes behavioral outcomes. This is a really well-established practice in the field, in the PTSD field. Imagery rehearsal therapy is what it's called. And imagery rehearsal therapy basically helps someone re-script a nightmare. You rehearse that rescription before you fall asleep. Often that rescription will take and the nightmare will change. Often once that change starts, you will never have that nightmare again. So could we take these techniques and bring them from, and the work that I've done is mostly with the VA in the States, can we take that from there and just put it over here? That's the bright idea. But yeah, anything on insomnia or on cravings, or if you hear this from patients, super curious.
Well, I'll just add that we do have patients that routinely tell us that they have dreams related to drugs that are very aversive and scary and that they're, out of their control. And so I think the points that you just raised are really insightful. And I had never considered that there would even be a potential to intervene on something like that. And it's really great to hear that things like that are routinely done in other fields. And it's a great example of how to bring perspective from other fields into the substance use space.
Yeah, 100%. I think there's a psychosocial sort of application here as well, in the sense that we often talk about this need to think beyond pharmacology and to think about the psychosocial drivers of substance use. So a patient, very easy now, I shouldn't say easy, but we can very effectively within 24 hours get people off of fentanyl onto agonist therapy. But if that was the end of the story, we would not have this crisis. Typically what happens is we discharge people right back to the environment that was driving their substance use. And we end up with this revolving door of detox treatment, discharge, relapse, detox treatment. And it makes sense that happens because the drivers of substance use can be so profound in people's environments, right? We sometimes use this analogy of treating somebody for gambling addiction in a facility, getting them to stop gambling, and then discharging them right into a casino, and they just walk into the casino, see all of their friends gambling, and saying good luck. So that's what happens when we discharge people, let's just say, back to the streets of the downtown east side. The point being that it's important to remove people from that environment, remove those triggers for them to have the best chance of recovery. But what sometimes happens is that environment will follow people in that treatment center, in their dreams. In their dreams, they're right back where all those drivers of substance use were occurring. So, and neurobiologically, we know that with opioid use, with alcohol use, you have REM suppression. When you stop using, you have REM rebound. And REM is when you're going to experience those vivid nightmares, dreams. So neurobiologically, it makes sense that you're going to have a rebound in dreams and nightmares. So to have this intervention, I think is a really interesting tool.
Thanks. I mean, no one else would let me try it, so thank you.
I just had a random thought. Earlier today, we had the talk about the DORAs, the dual orexin receptor antagonists, and how in opiate use disorder, yeah, what was it? I think it was an upregulation of the orexin, like something like that. There's a disruption of the baseline, I'll say. Those medications sometimes, like you'll have patients kind of report like these kind of parasomnias or like some sleep paralysis is like the 1% side effect. I think some people also report like vivid dreams on these as well too. I'm kind of curious, like what your perspective would be for. Like, does the DORAs therefore make it more pliable for you to do dream type of stuff? Would it make it harder to do dream type of stuff? I don't know. There's speculation, but I'm just kind of curious.
Oh yeah, for me, no, totally. I mean, orexin pathway, certainly things are going to happen with sleep. Certainly things are going to happen with dreams. Think about the parasomnias that are common in narcoleptics. So there's something going on tying those things together. But yeah, I mean, it's. I don't think it's just, oh, are the dreams more vivid or less vivid? Do you have less dreams or more dreams? Are they about the drug use or are they not? Because, I mean, after the Ellis study, there was another study which was published, which showed that if people had dreams of refusing the drug, that predicted actually positive outcomes in treatment. It's not as simple as they are or they aren't having them. And then, I don't know, I'm really excited. There's a whole field, there's a whole group of kind of cowboy anesthesiologists at Stanford Medical doing some work around propofol and dreams. It's really wonderful. I shouldn't call them cowboys. I'm like a huge fan, but I'm like, who let them do this? And so the very short version of it is, if you give people propofol and you don't wake them up really suddenly, you let them wake up slowly. About 93% of them report dreams, and those dreams are overwhelmingly 99% positive. It's pretty weird because in this room, we all go to bed tonight, probably 70% pretty negative, stressful dreams. A lot of fear in dreams, but not with propofol in your system. I have no idea why. And so I think there's like a whole question behind that question, which is what are the kind of pharmacological interventions we can bring to the nightmare space? People throw prazosin at this, beta blockers at this, but I think there's a lot more that you could think of. Yeah, so I just think it's a cool question.
Okay, yeah, super interesting stuff. Sounds like science fiction almost, but here we are. I want to, so I'll be shifting the focus back and forth a little bit. I want to go back to pharmacology, then we'll go back to tech, and then we'll go to youth and adolescents as well. But in terms of pharmacology, so we talked about the substance use landscape changing, the substances changing. Now, with regards to opioid use disorder, as we know, sort of the mainstay treatment is opioid agonist therapy. So essentially replacing illicit opioids with prescription opioids that are long-acting, safer, controlled, etc., addressing cravings and withdrawal. So the primary ones that we have are methadone, sustained-release oral morphine, and buprenorphine. So my question, and I'll direct this one to maybe Victor and Martha to start with, and others can chime in as well, of course. But in terms of, and Dr. Dunn, I would love your perspective on this as well, but in terms of induction strategies in the fentanyl era, what have you guys seen change, or what are the shifts that you've seen over the past several years, and what do you guys find being the most promising?
So I think one of them, okay, there's a couple facets of this. The most obvious change for the patients that we see with fentanyl use disorder is that the tolerance levels are much higher than previously perhaps we had been used to. It used to be the case with like heroin. You might use like heroin like a couple times a day, or if you're using like 4 times a day, you'd be considered like pretty heavy duty. And like you might stabilize on a dose of like methadone 60 or 80, and certainly doses of like 160 to 200 milligrams. Those are like really high doses of methadone, or so the legends speak. It's been some time since that's been the case. But nowadays, like we often see people who are so deeply within the addiction that their tolerances run to literally thousands to, I can't even do the math, like tens or hundreds of thousands of oral morphine equivalents per day. They're literally chain smoking fentanyl 24 hours and they can't make it through the night. So when you're dealing with tolerances like this, your standard opiate agonist therapies can't actually replace that meaningfully. So you can hit 300 milligrams of methadone. I've seen people in Florida withdrawals on 300 milligrams of methadone. So when you have situations like this, one, what is your end target? That becomes tricky. And then two, how long is it going to take for you to get there? So classically, when we use methadone, it used to be the case that you wanted to go pretty slow because it's got like a long half-life. You don't want to overshoot patients and cause toxicity. So you might increase by like 10 milligrams every 3 to 5 days. And that worked okay if you were aiming for low doses. Now you want to get faster than that because if your final target is say 200, you can't be waiting for 2 months for somebody to stabilize on a meaningful dose of methadone. They don't have time for that. Nobody's got time for that. They'll relapse. And so we need to look at induction strategies that are much faster. And so there's been a lot of new protocols that have been coming out. There's been fast ways to get people onto, for example, Cadian. You can rotate people from Cadian or IV fentanyl onto methadone. There's been a lot of work in this area to try to get people onto high doses of opioid agonist therapy within a more reasonable time span. So I think there's a lot of work that's been done in that arena. And specifically with buprenorphine, I think there's been a lot of work in terms of both like the macrodosing stuff, the microdosing stuff that have really actually quite revolutionized the way that this has been accessible for patients. And so there's a lot of promise there in terms of getting people onto such higher doses of opioid agonist therapy quicker and therefore more meaningfully. But at the same time, I think that we still have a significant population where we've quote unquote maxed out the doses. We're still not there, and then maybe we need to revisit. Is this simply just like an opiate deficit disorder? Is it like we're missing some other driving factors here? And then at the end of the day, there's also this question of retention as well too, which at least in Canada, our retention rates are actually pretty abysmal. I think we're like 20 to 30%, or maybe even less over 12 months versus Europe, which is 85%. And Europe is kicking themselves over their 85%, and we're nowhere close. So it's kind of, I apologize, a bit of a ramble, but there's certainly, there's a lot more urgency in trying to be able to get people onto meaningful doses of opioid agonist replacement therapy. And I think that we've got a lot of gap there. We're better, but we're not doing a perfect job of that for sure. So there's lots of room for progress there.
I definitely agree with a lot of the statements that Victor made. Certainly, with fentanyl and other high potency synthetic opioids, it is much more difficult to initiate doses of medications and to stabilize patients compared to during the heroin era. So that has required innovation in accelerated timelines, in super therapeutic starts of medications, and really pushing the boundaries for what we had previously considered perhaps risky or unsafe practices. And now in such a climate where any use is sort of that risk of Russian roulette and potential death, that really balances the need to move things along much more quickly. We've also been able to leverage existing medications and use them in alternative fashions. So depot buprenorphine in particular, 6 years ago when I was finishing training, this was a medication that was used for individuals that already had relatively stabilized opioid use disorder. They were looking for more freedom in their day-to-day functioning so that they weren't sort of, handcuffed to the pharmacy or needing to go on as consistent a basis, wanting to travel and go abroad. And so it was a medication that we could use for self-tapering. In the COVID-19 pandemic, as these overdose deaths continue to climb, there was a recognition that while medications like methadone or sustained release oral morphine, in theory, have help individuals develop a tolerance, which then reduces their likelihood of overdose, we weren't seeing that impact in the same way. But that was actually demonstrated with among individuals on depot buprenorphine. And so with that change in practice, what has made that medication much more frequently utilized, which is also helpful for adherence and remaining on the doses. I think what's really unique in this situation is there's been a very bidirectional conversation. So between frontline providers, clinicians who are actually using these medications for patients, prescribing these medications for patients, and in discussion with industry, actually recognizing that the existing doses or the loading doses and formulation that was developed is insufficient. So that's actually allowed for changes in the product monograph and global access to different ways of using this medication much more effectively than in the past. The final comment I'll make is just around the continued evolution of the unregulated drug market. We have been playing catch up for years and years, essentially for the last decade since fentanyl and other synthetic opioid became the dominant trend in the unregulated market, and then started seeing benzodiazepines and now xylazine and medetomidine, which has really pushed our boundaries and our evidence base. So where we previously were able to use these same medications to stabilize individuals fairly effectively, now we are not able to do that as easily because there may be lingering unmanaged other or unrecognized other withdrawal symptoms, and needing to target this from multiple directions, potentially with medications that we don't ordinarily try to co-prescribe because of potential risk, and really needing to innovate and push that in different ways.
Yeah, I'll just add. So I think I agree with all these comments. I think they're really compelling, and I'll add that I do think that we have made big changes in how we can initiate people onto buprenorphine, but I'm a bit dismayed that it took this kind of public health crisis to have this innovation. And I think if you look back at the history of substance use, that's when innovation happens, is that we have this gap, this public health crisis, and then we find a solution, but then there tends not to be a lot of additional kind of development and transformation after that. And I'm hopeful that we can move to a point where we just continue to invest in it, that there's kind of broad investment, and we've had a lot of public health attention now on this crisis that I'm hopeful we can sustain, so that we don't feel like we're playing catch up all the time, and then we can kind of get to a point where we feel really stable in how we treat our patients, and then we can push to do even better after that.
Thank you for that. Excuse me. I think just building off the theme that was mentioned, this concept of this rapidly evolving substance use, substances that we're finding in the illicit drug supply. I want to shift, and now shifting themes a little bit back to technology, and this was going to be directed at Professor Sammis. We've had to innovate on that front as well, just to be able to delineate which substances are showing up where and how quickly, and to be able to characterize the current illicit supply. Can you speak a little bit about the track and trace program and how we've tackled that problem through technology?
Oh, absolutely. Actually, I'm going to go through all our projects because they're all kind of related to what we're talking about today. So a lot of this started with detection. A lot of this, in fact, most of the reason I like working with Pouya is the Pouya lab has some interesting that they know what the issues are. They can bring us some really interesting challenges, and we can tailor the solutions for them. So one of them is rapid detection of these bedside detection of opioids. The current gold standard is LCMS. It's used in every hospital. It's used in every facility. Really expensive. Can't really apply it globally. So this is something that Professor Bazzato and I at UBC, we've been working on electrochemical detection. It's really fun, made cheap technology. Like, you think of it like a breathalyzer. Breathalyzers are really cheap. Everyone field deployable, everyone could use it. So we've been working with the Azar group now for over a decade, working on these electrochemical detectors to try to find very, very quick fentanyl detection. And talking about, I'd say, part of the reason things go slow is people invest in technologies and then they don't move.
That's right. And
that's been a struggle all the way through, I'd say, this entire thing. IR detection, they use this at every standard every rave, they always have these little IR detectors. Those don't detect lethal dose even, right? They're like 10 weight percent in terms of drugs. You have a lot of fentanyl in there, no problem. A lot of but carfentanil, it won't detect it. Sugars obscure it, and think of how often sugar is an adulterant in the supply. We showed groups a long time ago simple electrochemical detection, and we're well under lethal dose. And it's taken till now to get actually movement on that particular front. And actually with the Azar, we've been to get some really good movement on that front. Another challenge we were talking about was diversion of the opioid supply. How do we detect diversion? In fact, this is what the Azar group presented. And when we got together a team of scientists at UBC, this is not just me, just so I'm really clear. I'm going to be one representative of a lot of different scientists, both on chemists, pharmaceutical scientists. We all got together and we track opioids. And how can we do this? What could we roll out tomorrow? What could we roll out in 3 years? And what's the 10-year pathway? And then can we get started on these? So one of the ones we're looking at is, and this is what we just rolled out today, that's what the big provincial announcement was today, was We have technology overall for metabolomics. You look at blood, you look at all the little metabolites in blood, and you try to correlate it with disease states. We're effectively doing the same thing with the opioid supply. That's really what we're doing. We're fingerprinting detection of the opioid supply, especially the illicit opioid supply. Every time anyone manufactures fentanyl in a legal lab, it's not going to be pure. The one thing chemists can do is purify. That's actually what we spend. In fact, I have some students in the audience. That's what I train most of my students to do, is purification of chemicals. In the illicit market, you're going to see a lot of impure things. And that actually, every batch has an impure fingerprint of what you're trying to do. And then you can actually track by batch. So what we're going to be looking at is looking at the street supply, the illicit supply, and we'll see if we can actually fingerprint those batches and look at them not just in terms of location, but temporal shifts. Can we see where the batches are traveling from one area of the province to another area of the province, if we can track that? If the drugs are super pure, that could be a diversion issue, right? There's no way these drugs are making them as pure as an industrial laboratory. If it's dead pure, we know that's diverted supply. That also gives people interesting intelligence about what to do for the next step. So that was our, what can we roll out tomorrow? That's what we're doing. We actually can start this. In fact, we have started this already. What's the 3-year plan? The question is, again, a diversion issue. How do you actually put a little molecular fingerprint on each of the drugs? And we talked about different ways to do that. What's ethical, what's not going to change the structure of the molecule. And we have technology, again, we just have proof of concept that works in our laboratory. In fact, the guy who developed this in the audience today. It's basically, we do isotopic labeling, but we can isotopic labeling in less than 0.05 weight %. So very, very, very low concentrations. And based on the isotopic labeling differentiation, we can do D5, D6, D7, D8, you name the isotope. We create a fingerprint. It's a little barcode, concentrations of each of those isotopes as you go through. They already use isotope labeling in drugs to check metabolism. It's a common thing already. So we'll pass the FDA quite easily if we do this. We can now do thousands of codes. We already have proof of concept that works. We know the differentiation at this point. It's a little bit more research to do. Then we'll get the paper out the door. That's a 5-year timeline, because we still need to go through the regulatory agencies, but it gives people the ability, and this is now the use case. I don't worry about the use case. I let Professor Azar do the use case from that side. And in fact, I'll let you talk about potential use cases. But effectively, it's an easy signature, and it's really hard to replicate for any drug lab to actually replicate these little barcodes. And especially if we assign barcodes, we know when someone's actually trying to replicate that barcode. And then the long-term plan, and this actually gets a little bit the last topic we're talking about, you can change paradigms. You can use existing drugs to get that. And that's you have to do it. Like, that's short-term. Long-term, you got to come up with new solutions, new pharmaceuticals, new approaches, because the current drugs aren't really cutting it. Right? We're struggling, it sounds like, to keep up with this. The next challenge is, how do you actually develop new pharmaceuticals, new approaches, and innovative approaches? I've been working again with Professor Phillips on this, working with Pouya on this. What can we do to help develop that next generation of drugs to help address these kind of overdose and the opioid agonist treatments? And that's a longer term plan, though. Drug development's at least a 10-year runway. But this is the time to start. Right, we need to start light these fuses so that by the time one hits, we can hopefully hit that next crisis as you go across. So anyway, that's what I would say from the tech side.
Yeah, beautifully said. No, I feel like I don't have much to add to that. Adam, is there anything you want to add from the tech side?
Oh, from the tech side,
Yeah.
On my side.
Yeah.
Sure. I mean, I think. Hello. Yeah, I mean, I think from my side, I'm sort of a EE sensors person a bit, sort of split between brain science and sensors. And if you do decide that you care about the kind of sleep that your patients are getting, I can say that the tech landscape has completely changed in the last 5 years. It's insane. So we're starting a collaboration, and I was pretty curious about longer term monitoring of sleep quality. And a friend named Antonio has made a device called the Aware, just as an example of how much this is changing. And it's literally, it's like a continuous glucose monitor for your brain. So it's a sticky piece of hydrogel you can put on a mastoid or on your forehead, and it's a single EEG channel. And on one battery charge with one sticker, You can send someone home for a week and get a week of continuous sleep data from this little object, which is about the size of maybe half of your thumb, sits behind your ear. And there's never been a possibility for anyone who's outside of a clinic to get a week of data on them and say, oh, you're having this many awakenings, insomnia is related to this behavioral outcome. When you have this shift in your mood, it seems like you have this shift in your sleep. And that's battery technology, which is changing. It's the fact that this person happens to be like an incredible like BLE cell phone tower engineer, and you can do the communication side of it. That's really cool. It's the hydrogel. It's that people care about monitoring their brain all of a sudden, and you have a consumer market that's also driving these clinical changes. So like, I don't know, in my world, it's brain monitoring has completely changed in the last 5 years. Yeah.
And I think the take-home story is that clinicians working closely with scientists, presenting clinical problems, asking for help, and coming up with a united solution that we could never do working in silos. Now, I want to shift the gear a little bit to youth and adolescents. So I'm going to look to Naeem, our average 15-year-old, as well as Martha Ignaszewski. But we've spoken a lot about opioids, and certainly that's forefront in terms of our thought today with regards to the public health emergency that we're dealing with. But I think we need to think beyond opioids. There's always something new impacting our young people. So I've asked Naeem to talk a little bit about what he's seeing amongst his peer group in terms of substances and substance use.
Yeah, so well, when I asked to go to the bathroom in math class, I'll go into the bathroom and it just smells like kiwi strawberry with a mix of marijuana, right? But what I found more interesting, but that's not just like vapes or weed, is something that stems from this trend on social media called looks maxing. I don't know if any of you have heard of it, maybe a little bit, yeah, but essentially what looks maxing is a trend of primarily adolescent boys, like ages 15 to 20, and they're just trying to get their looks up. They're trying to make their physical appearance better, right? And where this becomes bad, right? You might not think it's bad, like, oh, they want to do skincare, go to the gym. But there's something called peptides, and like there's 15-year-olds injecting research chemicals just to get better skin, right? And these are not like FDA approved or for the most part. I don't know if you guys have heard of Ozempic. That's a peptide, but yeah, it becomes a problem when you have like 15-year-olds, 20-year-olds taking excessive amounts of research chemicals just to make your looks better. And like, there's people getting cancer from some of these stuff. There's not much research on this. And I think it's something that's really important. And it's surprising to a lot of people. Like, who would have expected this, right? Yeah.
Building on that, and really speaking about substance use, is one of the most famous influencers that really supports the looks maxing and has been a huge proponent of this, besides peptides, has actually been microdosing crystal methamphetamine and suggesting this as a strategy to improve your physical appearance, to maintain a healthy weight, to be appealing to the opposite sex. And this is all over social media. It is marketed to young teens who are impressionable, who's, at that young age may generate some of their self-esteem and the way that they feel about themselves based on the physical appearance or the responses that they get from friends, peers, others. We know that risk of social contagion is really high. On the topic of technology, we've heard about here on this panel some really incredible uses leveraging technology to kind of move our field forward. And certainly technology allows for that, the access to the internet, thinking about AI to be able to move some of this forward. I think are very interesting applications. They also have a downside, like these kinds of influencers getting a voice and really then being sensationalized and magnified. This is also social media in particular, and cell phones are the place, and other like internet platforms. These are the places where teens are spending increasing amounts of time. There is very little regulation, very little parental oversight, and it's very easy to become impressed by something and for that to become reinforced. And so we're seeing a lot of risk with that. There's been, recently landmark trials in the US actually looking at social media and the way that it was developed using psychological techniques and operant conditioning similar to slot machine gambling to actually lure people in, right? So if you think about the like on Facebook, that's both reinforcing. You never know when you're going to get one. So that's kind of like pulling the slot machine, but there's also that stress of it. So you end up with a cortisol bump, and that combination drives people to continue looking at that. So, I think at one point there were questions like, can social media or the cell phone even be considered addictive? And the answer is yes, absolutely. We see that with video gaming. We see that with a number of different behavioral addictions, as they're called now. And they have very similar phenomenology actually to substance use addiction. Individuals can develop dependence where they need more and more of the stimuli to get the same effect. When you take it away, individuals will have similar withdrawal symptoms, some of them physiologic, some of them psychologic. So this is a really underregulated area, I think, right now that can be used for good, for science and innovation, absolutely. But we do need to be cautious.
Right. No, I agree. There's an interesting phenomenon that I just want to quickly go back to. This was new to me, the whole peptide movement, but there's this interesting cultural movement that's happening. So it's the black pill, white pill movement. And so maybe Naeem, can you talk a little bit about what that movement is, but also like the drivers behind that movement?
Yeah, well, black pill I think it's bad. I mean, like they're having.
Can you define it?
I mean, I would define it as improving your looks no matter the consequences. Like people will give themselves bone calluses by like hitting their face with a hammer or something. It's pretty much self-harm, right? But I think a lot of this is driven from just being insecure. Like I think as a teenager, like there's a lot of things that can make you insecure, and especially on social media, especially spending like half your day there, like when you see the top 1% of the 1% look really good or have an amazing physique, you don't really care about the downsides if there are some, and you're really willing to do whatever it takes for the most part for the people in these communities. And yeah.
And then the white pill.
And then there's obviously a counter to it. Like we were talking about a little bit before, a shoe horse analogy, where on one side, you're just taking care of your skin or going to the gym and wanting to be better. And then on the black pill end, it would be just microdosing meth for just to have a lower body fat, right? And like there are people on social media that are trying to stop kids from using drugs to look better, but it's really bad because there's more people that are doing this and it's becoming more popular. Like I know people using peptides. I'm sure some of you might, and yeah.
I mean, it's just incredibly complex because, going from what you're saying to what Martha is describing is you have social pressures, you have technology involved, you have technology that's highly addictive, it seems like. And now you have these chemicals or peptides, so you have substances involved as well. And it's a strong interplay between all of these factors that's driving these phenomena. Much different than when I was 15.
Yeah, much different.
Yeah. Okay. So, so now it's been about an hour. I do want to leave time for questions. So we've jumped around and talked about multiple different topics. We've talked about pharmacology. We've talked about technology. We've talked about youth and adolescence. We've delved into the dream world. And I think this speaks to the complexity of the issue that we're dealing with and the need to approach it from multiple different facets to be able to make a shift in terms of the ultimate number of overdoses that we're seeing. So having said that, I do want to turn it over to the audience, and we can field as many questions as you like for the next half an hour. Yeah, go ahead.
Tap it again.
Okay, so this is mostly for the clinicians. So you saw a drive in fentanyl when you first started your residency or something, and I'm sure all of you on the panel had to go out of the box to try something very different or not the normal guidelines. And I was wondering what kind of challenges you faced into trying something new, and like what are the lessons you potentially learned from it?
Who wants to take that?
This sounds like a great one for Pouya.
I just received a couple of text messages that I'm doing too much talking. So I'll keep my answer brief. But like I mentioned earlier, I think it's rare in the history of medicine where we've had such a pressure to innovate. And we quickly found ourselves in a scenario where our tools were not effective. Now, we needed to innovate. We had to come up with new ways of treating our patients. At the same time, we had to be responsible, right? We couldn't just do things because they seemed like a good idea. So what I describe and the process that we went through in our group was we tried new things, but we tried things based on clinical need, what we saw in our patients. All of our protocols had pharmacological rationale, right? We tried them in a controlled setting. We got ethics approval. We did studies. We published papers. We contributed to the evidence void that we were seeing. And now many of our protocols are being used clinically around the world. But I think, so I guess I would summarize by saying that there's a need to innovate. We had to innovate, but we had to do it responsibly. And that doing it responsibly meant that we had to go beyond our own expertise, reach out to people like Professor Sammis, reach out to people like yourself, Sahiti, pharmacokinetics experts, et cetera, to help us develop these tools and then employ them. But, others on the audience?
I will say you're probably not quite giving yourself enough credit for how much you kind of innovated in this space. The culture of the practice of medicine, at least in Canada and probably in the United States, is that we are all incredibly risk averse to new things that are not proven. Our licenses depend on practicing within standard of care, and we can get very easily sued if we do things go badly and we did not follow standard of care. So anytime you go out on a limb to try something new that nobody's seen before, that pretty much any doctor is going to say, I don't know, this guy's off his rocker in the courtroom, right? You are putting yourself out there with quite substantial downsides potentially. So the problem was definitely evident at that point in time. Fentanyl was kind of revolutionizing what we were seeing for patients. People were dying in much higher numbers than has ever been seen before. To be able to recognize the need that's there and then come up with some protocols, again, done in a smart way, so at least you're kind of protected and not going full cowboy, if I'm going to borrow some terminology here. But it takes a lot of guts to do that, right? It's most doctors would not have risked what was risk to kind of develop things. And as the protocols have become more mature, people are more comfortable about them. A lot of the things that Pouya basically invented is now standard of care at Vancouver General Hospital. But without kind of a vanguard or a champion physician to take the lead in those risks, I don't think things get done as quickly. And I think to some degree that might actually also reflect why, not only in addiction space, but just in general, sometimes medicine moves quite slowly.
Just to throw a cowboy caveat in there, I think the story is sort of interesting about, this is Harrison Chow and Boris Hefetz and Pillar and Seagal at Stanford Medical. And I did say the word cowboy, but the way they started was kind of cool, which is it's sort of standard practice. People don't have conscious experience under anesthesia. If they do have conscious experience under anesthesia, you're having a problem because they might have an experience of their surgery. As an anesthesiologist, that's not what you want to hear. But if you talk to anesthesiologists, people are waking up all the time and saying, I had this crazy dream, I had this crazy dream. And so they had to listen to two things from their patients. The first one is they had to listen to patients wake up and say, I was having a crazy dream. And then patients saying, that crazy dream healed me, that I was having a nightmare for a very long time. Under propofol, I had my first good dream I've had in years, and I haven't had a nightmare since. And they had to take the person seriously, and they had to take the person more seriously than established medical knowledge. I think it was really the kind of cowboy part, as silly as it sounds, just listening to a patient and ignoring the whatever old heads are telling you it's impossible that someone's having a conscious experience. Turns out when you submit it to testing, 93% of people are having a conscious experience, even though everyone agrees that they don't. So yeah, it's just started with listening to folks and then being brave enough to send it on a study.
Mr. Chairman.
Sir.
I think it's easy to agree on the necessary innovation and whatever. That's not really the big thing. I think the big thing is that medicine, and especially psychiatry, is missing a really sufficient model of care and a really sufficient model of the integration of substance use disorder into its discipline. So we're sitting here as a group of interested people. I'm also appreciative that we have a chemist and somebody who's cares about sleep and whatever. So really, and a young advocate. But overall, so I'm an old psychiatrist, a gray-haired gorilla. But I think really the problem, you can only develop innovation appropriately and develop a strategy also together with other brains if you have a good understanding what's going on. You started the conversation with concurrent disorders. Come on, that's a close connection between mental illness and severe trauma and pain, which is not mentioned, is a big one, together with opioid use. But we're living also kind of, this is focusing very much on certain parts without a model and a structure and an overall theoretic approach how to develop a discipline. And I hope that the young ones here will be able to be more productive in that area. I think the biggest thing we are missing in addiction psychiatry or addiction medicine is that still most of our colleagues are refusing to work with these patients. So it's ridiculous that whatever Pouya has to run if somebody is going wrong with substance use in the emergency room of BCCH, and that not every psychiatrist can respond to these things. So I think I would really like that you getting as excited as I am about that thing and not so lame. Hey, let's work on that molecule. That's that medication. It's an overall bigger challenge we have to address. Otherwise, we can train also the next generation in an appropriate way. Just focusing on one little thing is not enough. We need to change psychiatry. We need to change medicine in general. And so, sorry, that's what's missing and where I get a little difficult to hold myself back. So sorry for a long speech.
I mean, no, that's a very good point. Thank you for bringing it up. It takes me back to the gambling analogy that I made earlier, where sometimes we treat our patients, but send them right back to the environment that was driving their substance use and expecting things to change. So I agree, we can be as sophisticated as we want with regards to pharmacology, technology, etc. But if we're not addressing some of the fundamentals that are driving people's circumstance, I don't think we're going to change move the dial significantly. So I agree.
This is the direction that my thoughts went listening to you, Michael, and to thinking about the panel. You know, we're talking about individuals with severe opioid use disorder who really are at the furthest end of the spectrum in terms of risk, acuity, and severity. I see patients in adolescents that are at that end of the spectrum. I also work with individuals who are at the very beginning of their substance use journey. They're experimenting, they're trying new things. That's part of adolescence, right? This is entirely normative. We all learn through experimentation and figuring out what went well and what didn't. And society in our world has changed fundamentally from the way that it used to be. Mental health among youth and young adults has never been worse. So in Canada, 1 in 5 young youth or young adults by the age of 25 will have a mental health or substance use diagnosis. That's talking about 20% of the population. A smaller percentage of that will then go on to develop the highest severity and go on to have needs with providers like us. But my thought is we actually need to move from a very reactive and sick-based system of healthcare to something that is much more preventative and much more focuses on resilience and well-being and health promotion, because otherwise we're just always going to be playing catch up. And this is what the evidence shows, that when we're working with teens in schools, even virtually and on social media, we're able to capture things much earlier and potentially prevent things from moving ahead in the way that they might have with some of that trajectory. So I definitely agree with the importance of starting with this early and really fundamentally transforming the way we approach some of this.
So 3 questions. Your hand went up first and then go this way. Go ahead.
Hi, so to kind of add on to that, I had a question specifically about ADHD, and I know how the prevalence of ADHD has increased dramatically, and this also plays a role in like the doom scrolling, fast content that we see on Instagram and other social media platforms. But I was wondering, because one of the for untreated ADHD, they chase dopamine rushes a lot of the time by like binging food or like doing new projects, video games, etc. So I was wondering if this could potentially impact the prevalence of addiction and maybe even substance addiction we could see in the future, or how this might play a role then in this chasing of dopamine.
Thanks for that question. ADHD is a really interesting diagnosis conceptually. It's both over and underdiagnosed. So we actually have a very difficult time accurately diagnosing ADHD, and there's a number of different reasons for that. As technology has changed, our attention spans have also changed. So in the 1980s, when you were watching TV, there were maybe 10 still shots in a single frame. Nowadays, it's upwards of 25 to 30. When you're on social media, videos need to be very compelling and catchy, and you need to catch somebody's attention within 2 or 3 seconds before they make a decision. And so those kinds of experiences actually change what our brain is able to process and how we capture information. What the maybe not so hopeless side of that is that that's reversible. So if you do a dopamine detox, if you get off your phone, you're able to change some of these pieces. I'll maybe take it one step further in that, we think about dopamine as a feel-good chemical and putative in a lot of addiction and behavioral disorders, but it's actually part of our learning network. So we are having dopamine bumps throughout our day, whether that is through something that we eat, through getting positive feedback from somebody, from engaging in a preferred activity. So I think there is risk, definitely, as we're continuing to chase dopamine and looking for, needing higher stimuli to get the same effect. And certainly social media plays a really big part in that. Hard to say, is that going to continue to increase numbers? There may be sort of antidotes to that. And increasingly, we're seeing teens that are signing off of social media. They're using dumb phones to try to actually escape some of this. And so again, I try not to be very black or white in one direction or another. I think technology has great applications, but we do need to be a little bit safe and mindful in terms of how we're using it.
Dr. Chada, I think you had a question.
Hi, thanks everyone. Martha, I really appreciate your comments about the prevention piece, because that was coming to my mind. So I have 2 questions for the panel. One, a little bit about whether there's technology forthcoming for the prevention piece, because ultimately addiction is a symptom of a bigger disease, which is what we're sort of elaborating on here. And then the second thing is, maybe Martha, I don't know, or others members of the panel, what are the epidemiologic data internationally for these diagnoses we're talking about? Because one could imagine that in countries that have less availability of social media or internet or different things like that. Of course, there's confounders like how quickly mental health is diagnosed, how much attention, how much money there is for that. So it's a really broad question, but I'm just wondering, and sort of like when we look at emerging economies versus advanced economies, if there's a difference, and like, are there lessons to be learned from other places that don't have these sort of illnesses that I think in my clinical work are from disconnection, like a community and generational trauma?
So I'll take this one. I guess it was directed to me. So there is definitely a divide in terms of more developed countries, largely Western countries, where we are seeing this pervasive use of technology, social media, internet platforms. Some of the Asian countries are leading the research in terms of information about internet gaming or video gaming and internet use disorder, because this is a very widely accessed tool, for lack of a better word, I guess. But when we're looking at developing countries where teens may not be in schools, may not have access to the same pieces, while there are mental health challenges, these tend to be very different than what we might be experiencing here. Certainly trauma, and especially with changes in the environment, we're seeing displacement and other issues in that way, but not necessarily the same incidence of like depression or anxiety in the same ways.
Just two short shout outs to add to the last questions. I think if you're concerned about the attention fracking or attention span, results of social media, etc., the AI Dilemma film that is out like this week from the Center for Humane Technology and Tristan Harris is an incredible film. And those are the folks that put out the Social Dilemma years ago and tried to warn all of us about the world that we're living in right now. Just came out this week. Incredible group, also really interesting group of litigators, also really involved in the lawsuit against Meta, also really involved in the evidence behind the claims that attention, that technology is in fact addictive. So anyways, AI Dilemma is a dope film. It's out. It's really important. Just on the prevention, I think Pace also, I don't know, this is just an idea to sort of throw out to y'all. You know, in the context of like civil engineering, I got given this metaphor recently. We reinforce a bridge before a hurricane, not after the hurricane hits. And so often in the case, for instance, of like homelessness, we are there after the bridge has been destroyed, after the house has been lost, and it's hard to get someone out of a cycle of homelessness. And so I was just reading about an intervention program which looks for the predictive signs that someone might lose their home. Oh, a job is lost. Great. That's when we should show up with an injection of capital so the person doesn't enter a cycle of homelessness. Look for a predictive signal, and then you end up paying a lot less as a government to intervene in the cycle of homelessness early on. I'm curious if there's something similar with substance use disorder. Oh, we can see in a public health perspective, it's likely maybe job loss is another one, that this might be the beginning of a road down towards substance use disorder. This is when we should do a targeted intervention, and that's like a big data problem. So I was just curious about that from to the prevention question, if there's anything like that in your worlds.
So there are a number of mental health and substance use prevention programs. There's probably upwards of 20 or 30 of them actually that have been developed. Sorry, I got distracted. In terms of how widely used they are, the uptake is actually very low. So, and that's despite actually pretty good evidence. So there's various reasons for that. A lot of this research happens in healthcare and academia, doesn't necessarily get translated to spaces that youth are. BC is actually leading the way in this with a Canadian prevention paradigm called Preventure. It was developed out in Montreal and is now going to be, I think just as of last week, going to be across 100 previously 80, now up to 100 schools across British Columbia. It's geared towards 14 to 16-year-olds and uses personality traits to characterize individuals into groups and then to develop an understanding and education and coping skills for how to address or reduce their substance use. And it's effective. The research from this model has a 35 to 60% reduction in substance use. And there's many others that are also effective. There's one that's being piloted for the first time in BC, but has been used all over the world. That's called Planet Youth, or the Icelandic Prevention Model. And this is community-based programming. It actually comes even earlier than the academic piece, trying to look at community safety around substance use, and came from evidence in Iceland, which for some of you that don't know, can be part of the land of the midnight sun and the opposite. And so especially through the winter months when you can't be outdoors, when kids can't be outdoors and can't be having fun, they found many other activities that usually weren't as healthy or health promoting and were getting themselves in a lot of trouble. So the community got together to actually build access to fun activities, whether that was sports or aesthetics or kind of other pieces, but it really required a huge influx of investment and time and resourcing from the community, but can be very effective and leveraged across different places. The trick with these right now is in BC, where historically teens started using substances around that post-puberty time. Nowadays, we're seeing teens using substances earlier and earlier. So the Adolescent Health Survey, which comes out in BC every other year, shows that teens as young as these aren't even teens, these are preteens, as young as 9 or 10 years old are starting to use substances. So even for those prevention programs, we're already a little bit too late. So this needs to be something that we talk about in our families, we talk about with our peers. One of the things that I talk with a lot of my family and friends about is if you're not talking to your kids about substances, they're going to be talking to somebody else about it. And that somebody else is either going to be social media, TV, which is going to present a glamorized or romanticized perspective, or they're going to be talking to their friends or their dealers who have an ulterior motive in this situation. So this needs to become part of our daily vernacular, especially when overdose deaths are the leading cause of death in this age range and in adults as well.
I think one of the things we're doing in our lab in terms of prevention, I think is interesting, is we looked at this problem about 2 years ago, and we started to think to ourselves, let's just look at what's driving young people's behavior, good or bad, etc. What are the main influences? And we sort of settled on social media, the power of social media influencers as being one of the most significant driving factors for young people's behavior. So then the thought was, is there a way to harness the power of social media influencers to bring about positive behavioral change, right? Can we inject the quote unquote cool factor into talking about mental health and addictions? So we came up with a campaign. It's going to launch, Alex, when are we launching? Next week. Now it's called Natural Stance. And we essentially took an approach that a brand might take that targets young people. So in terms of having spokespeople that are influential online, having merch, stickers, real branding around logos, etc., true branding around that's cool and appealing to young people, but around the topic of mental health and addiction. We wanted to start small at a subculture of young people and then create a model that can then be expanded to other subcultures. So we started with skateboarding youth as our target subculture. It's primarily done through social media. It's launching in a week. I think it's cool. Sahidi's wearing one of our shirts. If you want to stand up, Sahidi. That's just an example of one of our hoodies. But it'll be interesting. And we're going to evaluate it scientifically, pre-post exposure surveys, and to see if this is an approach. We know social media is already impacting young people. Can we harness it for good? So that's sort of the approach that we're taking in our lab when it comes to prevention. Okay.
I wanted to touch on that second question that you had, which was how does this compare to other countries? That made me think of a talk that was at Hamburg last year at the ISAM. One of the speakers was talking about how if you look at trends for alcohol use in emerging economies in Southeast Asia and kind of in Australasia area, right? That you could come up with a couple interesting observations. And one of the observations was that the amount of alcohol use disorder directly correlated GDP. As people got more money to spend, they spent more on alcohol. Kind of makes sense. But there was an exception for the countries that were Islamic, which makes sense because you don't have alcohol in those countries and the religion means that you can't drink. So then it was just flat. So there's like a grumbling low level of alcohol use disorder, but the GDP went up. The one exception was China. China blew up in terms of their GDP, obviously, and then their alcohol use disorder concurrently also went straight up. But there was a massive policy change that was enacted some 10 years ago or something like that, where the rates of alcohol use disorder dropped dramatically. And the policy change had to do with the amount of reimbursement that the government gave out for alcohol at functions for work dinners, of which usually people would attend 2 or 3 a night. So that's an example, I think, where you can use it's a case example where it shows that policy and culture have a massive impact on overall population level substance use disorders. And you can kind of conceptualize a person and their risk of substance use as having multiple rings of defenses. And the policy and the culture is certainly one ring of defense. And then inside of that, the individual is its own thing. So that's all of these different strategies of you have to teach people about the consequences of drugs. Drugs are probably not good for you, right? If you don't have that, then your first ring of defense is gone. But like nobody wakes up and says, I want to grow up and be an addict. Like that's nobody's agenda, right? But there's somewhere where they have failed, a Swiss cheese model, so you will, where you have these rings of defenses. All of them failed at the same time for this person to have fallen into that. So mental health, having strong mental health would probably be another one of those. Having like, good psycho, like a good socioeconomic status would be another one of those. You're not homeless, you're not abused, that sort of thing, right? And so you have to have all of these factors fail you, or at least 75, I don't know, making something up, some threshold that has failed you to actually put you down into the Downey side, addicted to fentanyl. So I don't think it's adequate to have just dope, adequate to just have housing, adequate to just have this. You need to have the whole picture, like Dr. Krause is now missing. But you need to have like a whole integrated system that kind of takes into account policy and culture and stuff like that, and see what you're working around, right? And part of that also is like culture is not something that we change. It's just something that dynamically happens. It's very hard to physically enact changes in cultures. We're just going to say that we can't do that. But policy you certainly can change. And policy is tricky because I think that policy most of the time tries to be evidence-based, but there's a lot of time where policy is sentiment-based, and that's where you run into trouble. So then like, you have to have advocacy in the government and stuff like that, and you have to try to pull your piece and try to do what's right, even with the limited evidence base that we have.
So maybe 2 more questions, and then we'll try to finish off. But go ahead. I think you had your hand up next, and then in the corner, Jane.
Okay, great. Thank you. I just had a question about an earlier topic in terms of adapting your systems to like the dynamically shifting drug markets, and how we mentioned there's potentially a new detection technology with molecular fingerprinting. And I was just wondering how that might actually look like in practice. So whether it's in toxicology or drug checking, and how can we integrate that into the systems of care, like for example, in clinics or acute care?
I'm going to answer the really flippant answer first before I answer with, I think, a more real answer. The flippant answer is, I'm just the tech guy. There are a lot of people out there who are much more familiar with the healthcare system in terms of how to actually use this technology. So on that side, that's my flippant answer. On the more real answer for you is, the more information I can provide, the cheaper I can make it, the more translatable I can go from an academic lab to a clinic to, let's say, hospital first, because it's easier with the resources, then to clinic. Give me just a second, I apologize, and so forth. That will depend on where you can actually see this technology, right? So effectively, my job is to make it as translatable and cheap as possible and as quickly as possible. That's on the tech side. I would say the answer in terms of new drugs out there, that can be detected in terms of the fingerprinting, and we can just look at the analysis. You can look at the drug. I can tell you what the precursors are there too. Like, it won't take that long to figure that one out. A lot of it is just translating that information out quickly. And then how it's implemented, that's where I'm kind of being flippant. It depends. Clinics are going to be different than hospitals, are going to be different from rural communities, can be different from high population centers. My goal is that this is applicable to everywhere. That's why we did some of this electrochemical technology, because it's easy to use. That should be applicable everywhere, available, cheap, no problem. Some of the other technologies that we're working on, I can almost guarantee you we can't deploy this everywhere. But the idea is you should be able to have a cheap way of shipping the drug samples to us. And my goal is, as a UBC lab, I don't want to be a drug testing facility long term. We're just an incubator for the technology. Then we're going to bring it out to people who can deploy this more readily. Does that answer your question, I hope?
Yes.
That's right. There's a follow-up over there. Yes. Yeah.
Other questions for like the academic or the clinical standpoint, for the like actually treatment addiction, opioid, how much does it matter? Because people who are like actually inside and dying, they don't care about like so what does that do for them?
Fantastic question. Actually, I'm going to pass this to Professor Azar because we work very closely on this particular topic, and he really works with the health use case for this particular aspect. So,
yeah, that's a good question. I'm an addiction medicine specialist. I work primarily in the emergency department. We have patients present to the emergency department with toxidromes that we may not recognize, which are difficult to treat, which we may not have treatment protocols to address. I'm sorry? So these are treatment protocols that we can use today to treat patients, right? So what the information that I need as a physician is, what is that individual using? What is the expected toxidrome? And how can I treat this individual? So if we have a system to analyze substances that are in the illicit drug supply, and if we have a way of knowing where these substances are showing up, and imagine if we have a way of predicting where they're going to show up next. We get information through our program that Williams Lake is going to have substance X show up in the illicit drug supply. And with this information, we can say that, let's just take methamphetamine as the most recent one. We expect methamphetamine to show up here. This would be the toxidrome that you might expect for patients. This is how to test for it. And this is how to treat that patient in front of you. We can deliver treatment much more effectively, more quickly, instead of having to play catch up. The toxic drug supply has evolved much quicker than we've been able to evolve with it. So we're constantly playing catch up. This is a way of getting ahead of it. So that's one way of directly impacting the way we treat our patients. There's a harm reduction approach here as well, right? So people that use substances, I think information is important for them, right? To be able to more accurately predict that, have an early warning system for people who use. Expect substance X to show up in these locations. This is what you should look out for. These are the things you may need to do to reduce the harm associated with your use. That's a sophisticated harm reduction early warning system that can be deployed for people who use. So I think this is an interesting picture where technology can help us treat patients more effectively, but it can also help us on the harm reduction front to help reduce the harm associated with substance use as well. That makes sense, yeah.
Actually follow up a little bit with that is we're not looking to replace what's out there existing as well. We're complementing, right? Like drug testing facilities, fantastic. The ones that are currently working there, they're doing a fantastic job with what they've got. Yeah, so I'm not disagreeing with that, but what I would say is I've looked at all the data out there. I've looked at what Health Canada provides. I've looked at what the drug testing centers provide, and they're woefully deficient for what you actually need. Woefully deficient. Yeah, effectively. Now I would say, like the drug testing facilities are great. They do their job. It's better than nothing. It's fantastic to have, and they're making great progress on that side as well. So I don't want to say anything there. The Health Canada data is about 6 months behind to most municipalities, right? So, I mean, we just talked to one of our collaborators in law enforcement today, and they're trying to figure this out. And they had metamidine a case, and yet the Health Canada data said there's no metamidine currently in that particular jurisdiction, right? It's way out of date. So for what we're doing effectively, I just want better testing, more granularity in the testing, more data. I'm trying to provide the people, like Professor Azar, more data to make informed decisions moving forward. That's really my goal with all of this.
Okay. I think there was one question over on this side. Sorry, Jane. Yeah, go for it.
Hello.
Yeah.
Hi. I have a question for Dr. Dunn and Adam. Dr. Dunn, earlier in your talk, you were talking about the potential role of orexins for treating opioid withdrawal. I was wondering if orexins had played any role in like the nightmare sort of space, and as well as what kind of mechanisms you think orexins have in potentially treating withdrawal.
Good question. So we approached orexins because we wanted to treat insomnia in people as they were withdrawing from opioids, because again, we knew that that was one of the leading symptoms that we needed to treat. It also had we had reason to believe from preclinical studies that it had meaningful interactions with the opioid system, and then it could alter drug self-administration in ways that we thought might be predictive of the response in people. I will say I was very surprised at the magnitude of response that we had and how positive it was. And so for those who didn't see the talk, that we were able to increase sleep time in people that were withdrawing from opioids by an hour and a half, which was several times more than what the FDA would have needed for us to have that medication approved for that indication. And not only that, but and being somebody who's worked with these patients for a long time, I could physically see differences in them. And it was really, it was amazing to me. And they themselves, I've never run a treatment protocol before where people said, I don't know what you're giving me, but I would really like to continue taking this. And so it really seemed to have these really beneficial effects. And then we saw these I guess it's, in hindsight, we should have predicted it, but we weren't expecting to see meaningful, significant differences in withdrawal management as well as craving that we did. And I should mention that these were independent effects. It wasn't that they improved withdrawal because they were sleeping more. It was, we had both improved sleep and also improvements in withdrawal and reductions in craving. So I think our understanding, I think essentially the data I've actually become very convinced that the orexin system is driving a lot of the universal symptoms that we've talked about, particularly the craving and the insomnia. And there's, I think, converging preclinical evidence to suggest that it's really meaningfully implicated in the continued persistence of substance use and various, probably multiple substance uses, not just opioid use. And so I think, I've worked my way back around, I think, to your question, that I think there's strong mechanistic rationale to support the medications. And now there's a lot of development of very specific medication. So it doesn't need to be both receptor antagonists, it's just a single receptor antagonist, which seems to even have a more precise effect. So I think that this is a good example for me. And, we had this idea, we wanted to repurpose an existing med to see if we could benefit a symptom from a new perspective. Then it kind of revealed maybe a whole new mechanism that we had been overlooking that has now driven a lot of research in this space that I think we could continue to do. I think you probably would have the expertise to speak about dreams. No, okay.
No. I'm assuming you didn't ask about nightmares when you get that extra hour and a half of sleep.
Right. Well, we didn't have anyone. So these were all folks that lived with us for 11 days. And I can't remember an incidence of people reporting nightmares in that setting. But again, people were sleeping. They were sleeping very well. Yeah.
Cool. Yeah. That's really, I'd love to learn more about that. I don't know about the project, but I'd be really curious. That's awesome. Yeah, I think the only thing I can add is that if you're curious about whether orexin has something to do with nightmares, look to the 81% of narcoleptics who have nightmares. I mean, something's going on. And that might be because there's some kind of direct mechanistic link. might be something sort of weirder. It might be that if you're narcoleptic, you end up in mixed sleep-wake states a lot. And those mixed sleep-wake states are very confusing for people and can produce a lot of fear. And that fear might then create a fear of sleep. And that fear of sleep might then create nightmares. It might be much more complicated, but it certainly seems to be the case that if orexin is wacky, nightmares can absolutely happen. And just to again hit the nail again on the head, there has been one RCT to date on intervening in nightmares in a population where 81% of them have nightmares, which is crazy. Anyways, I'd be really curious if you did. I bet people wouldn't tell you they were having nightmares unless you asked them if they were having nightmares. So I'd be curious.
We did collect a number of sleep measures. I can look to see if any of the items specified nightmares. We have had this before, though. So we've done studies with other medications for other indications. So varenicline, which is Chantix, we did a study looking at that as a treatment for alcohol use disorder. And then also independently, we had a second study running looking at it as a treatment for smoking, tobacco smoking. And the individuals who were receiving it for alcohol, we had a very high incidence of people reporting nightmares, very vivid, very concerning, disturbing nightmares. And we had no incidence of that in people that were using it for smoking. So I think, we've had it before, and I think it does probably reveal an interesting mechanism that I hadn't really thought about.
You might reveal a mechanism. It also might reveal a motivation for substance use in the first place, right? Like smoking a bunch of cigarettes isn't going to make you not remember your nightmares. Drinking a bunch of alcohol will make you not remember your nightmares. So you think about whatever sort of classic image of a Vietnam veteran uncle who drinks himself to sleep. Like that's because in part that means you're not going to have any REM sleep. You're not going to have any dream recall. And so if you're someone who is afraid of going back to your most traumatic moment, then you might choose alcohol as your substance of choice as opposed to, for instance, nicotine. So maybe those people who are, having their alcohol use disorder become less severe and having that REM rebound, it's that original trigger coming back. And so it's like, certainly to what Pouya was saying, as a relapse risk, it's a really interesting potential target.
Thank you. Okay. Well, I think if there are no more questions, we can start to wrap up just because it's that time and it's getting late Friday afternoon. So I just want to thank everybody for attending today, all your questions, thank our amazing panel for the time you've taken.